everybody. So welcome back to round 2 with me, Integrity. Hopefully this time it goes a little bit better than last time for everybody. Today on this recording we're going to be talking about diuretic agents, which is chapter 28 in your book for those of you who like to follow along there. And then for ATI it is chapter 19. So on this recording I'll be talking about some of the anatomy and physiology of the renal system, different classes of diuretic agents, and nursing care plans or nursing concerns for patients receiving diuretics. So diuretic drugs are used basically to accelerate the rate of urine formation, and this happens in a variety of different mechanisms, which we'll discuss kind of individually as we go through each one of the medication classes. And as the urine formation happens, it takes and removes the sodium in the water from the system. So these are commonly used for treatment of high blood pressure, congestive heart failure, glaucoma, renal failure, ascites from liver disease, different types of edema for various types of reasons, and also like hypercalcemia. So first let's talk a little bit about anatomy and physiology. So shown here is just like a simple drawing of a nephron within the kidney, and the kidneys each have about 1 million nephrons. And the kidneys play a very important role in filtering out toxins, but they also conserve essential substances kind of simultaneously. And this happens in the main structure of the kidney, or the nephron, which, like I said, is shown here. And then each one of the different diuretic classes exert their effect on different parts of the nephron. Now, I think during our fluid and electrolyte lecture we talked a little bit about where sodium goes, water follows, and this is true here in the nephron. So the initial filtering of the blood happens in the glomerulus, and this happens, sorry, what I meant to say is when this happens or how this happens is called the glomerular filtration rate. And then the proximal tubule follows the glomerulus, and here in the proximal tubule, about 60 to 70% of sodium and water is returned back into the bloodstream. But this requires an active transport system, which requires energy of potassium and sodium, which also then causes this passive transport of chloride and water through the system. And then 20 to 25% of all the sodium is reabsorbed into the bloodstream in the ascending loop of Henle. And then finally in the distal convoluted tubules, about 5 to 10%, and then in the collecting ducts another 3%. So if water is not absorbed back into the system, it is then excreted through urine. We're going to talk about several different types of diuretic drugs during this lecture. So here you'll see there's loop diuretics, osmotic diuretics, potassium-sparing diuretics, thiazide and thiazide-like diuretics, which basically work the same, and then the CAIs we'll also be discussing. So first let's talk about the carbonic anhydrase inhibitors, or CAIs. The most common of these is used as Diamox. They are a chemical derivative of sulfonamide antibiotics, and they inhibit the activity of the carbonic anhydrase, which works at the location of the carbonic anhydrase enzyme system, primarily in the proximal tubule. So for sodium and water to be reabsorbed back into the blood, hydrogen must be exchanged for it, and without hydrogen this cannot happen. So the enzyme carbonic anhydrase helps to make the hydrogen ions available for exchange with the sodium and the water in the proximal tubules. So the CAIs block the action of the carbonic anhydrase thus preventing that exchange of hydrogen ions with the sodium and water. And remember that here in the proximal tubules is where 60 to 70% of reabsorption happens. So when hydrogen ions are blocked and are not available, the exchange just doesn't happen. So reabsorption is decreased. So there's less hydrogen or less water and sodium in the system. So there'll be an increased excretion or more urine output or more fluid that goes out. So what are these types of diuretics used for? So they are used for adjunct drugs for long-term management of glaucoma. And just a small bit here about glaucoma for interest purposes. So it's a problem with a pressure buildup secondary to obstruction of the flow of aqueous humor, or sometimes it's because of an overproduction and we're not able to get rid of it fast enough. So you can see how a diuretic, when it increases excretion of fluids, can help in this type of fashion. It's also used for edema, epilepsy, which I am not really sure why it is used for epilepsy and couldn't find any indications for that, although it is listed in the book. And then also for high altitude sickness, which makes absolute sense, as what will happen is with high altitude or altitude sickness, there can be pulmonary edema or cerebral edema that happens. So drugs like Diamox are used for management of heart failure when other diuretics are not really working, but they're less effective than other classes of drugs of diuretics that are used. And part of the problem is that the metabolic acidosis they induce can reduce their diuretic effect in about 2 to 4 days. So here's just some of the adverse effects that can happen with the use of CAIs: metabolic acidosis, anorexia, hematuria, photosensitivity, melena or blood in the stool, hypokalemia, and because of the hypokalemia there could be, if the patient is taking digoxin, an increase in digoxin toxicity can occur, drowsiness, paresthesias, urticaria. And then if the patient is also using corticosteroids, this can also cause an increase in hypokalemia. Alright, so just a little glitch here, unfortunately, with knee integrity, and when I bring up this slide, I don't see the balance or the levels that are supposed to be showing on this slide. And if I change slides to see if it's on the next slide, we'll see in just a minute, then we can't really have much of the discussion. So I'm just going to read quickly this ABG result that I have here on my slide. The pH of 7.23, CO2 of 46, and then the bicarb level of 19. And if we go back to harken back to last semester in our conversation about acid-base balances, remember there were those 6 questions that you can see here on the right of the screen to ask yourself. And so the first one is the pH of 7.23 high or low? And here it is low because it's less than 7.35. And then the CO2, we want to know, is this normal? Well, the normal range for this is 35 to 45, so this is slightly higher than normal, but not terribly high at 46. And then the bicarb level, is this normal? And here we see that it's less than 22, so at 19 it's less than 22, so it is low. So what is the problem here? Okay, so what I've noticed is that when I change the slide, indeed it does come up. So the problem here is the next classification of drugs that we're going to talk about are loop diuretics, and these are very potent diuretics. They are structurally related to some sulfonamides, so in some folks that have sulfa allergies, there can be a problem, although this is not really often seen. But you do need to be aware that it can be a potential problem for them. So loop diuretics act directly on the ascending limb of the loop of Henle to inhibit chloride and sodium reabsorption, and they increase renal prostaglandins, resulting in dilation of blood vessels and reduced peripheral vascular resistance. So they have renal, cardiovascular, and metabolic effects, and then they have a reduction in vascular resistance. They work really quickly, so they are very useful when you need rapid diuresis to happen, and they also still work very well even when there's decreased kidney function. So we already said that they're a really potent diuresis effect that they have, but that also means that they have subsequent fluid loss, or they can cause a rapid fluid loss. So some of the things that you'll see with decreased fluid causes, so reductions in blood pressure, which could be helpful if what you're trying to treat here is high blood pressure. Reduced pulmonary vascular resistance, reduced systemic vascular resistance, which can be helpful for folks with CHF. Reduced central venous pressures, reduced left ventricular and end diastolic pressures, again can help with those kind of folks that have congestive heart failure. And then it does have a problem with potassium and sodium depletion, and to a lesser extent can also have some calcium depletion. So these types of medications are used for folks that have edema associated with heart failure or hepatic or renal failure. Again, I already talked about controlling hypertension, increased renal excretion of calcium in patients with hypercalcemia, although it's not primarily used for that, but it can be used kind of secondarily for that. And then certain cases of heart failure resulting from a diastolic type of dysfunction. So the main toxic effect is electrolyte and fluid imbalances. It also has both neurotoxic and nephrotoxic types of properties, and can produce additive effects when it's given with in combination with drugs that have similar types of toxicity. So if we look at each one of the body systems kind of separately, in the central nervous system, some of the adverse effects are dizziness, headache, tinnitus, or blurred vision. In the GI, nausea, vomiting, diarrhea. For hematologic, agranulocytosis, neutropenia or thrombocytopenias. Metabolic, you're going to see hypokalemia, hyperglycemia, and hyperuricemia. The next group of medications that we're going to talk about are osmotic diuretics. We'll probably mostly talk about mannitol, as this is the most common drug that I've seen given, and the most common that is given normally. These medications are given quite frequently to help with elevated intracranial pressures, but also there are some other types of medications given to help treat glaucoma as well. So these work mostly in the proximal tubule, and it is freely filtered at the glomerulus. It is non-absorbable, producing an osmotic type of effect, which increases osmotic pressure. It pulls water into the renal tubules because of that increased osmotic pressure from the surrounding tissues. And this process inhibits the tubular reabsorption of water and other solutes, which also produces this rapid type of diuresis. It does not promote sufficient sodium types of loss, so it's not generally used for folks with or those types of indications for like peripheral edema. So it increases glomerular filtration and renal plasma flow, so it's an excellent drug for preventing kidney damage. It reduces excessive intraocular pressure. That's why it's used it can also be used for glaucoma. And then it's used very often in cerebral edema resulting from head trauma. So it's used in the treatment of patients in early acute renal failure, and that's because it can only work if there's enough renal blood flow and GFR for the drug to reach the renal tubules. to promote the excretion of toxic substances, they have to have this increased renal blood flow. Again, I already talked about that. It is used for reduction of ICP, or intracranial pressure, and treatment of cerebral edema, so again, a swelling there in the brain. And then I talked about on the previous slide, I believe, that it's not indicated for folks with peripheral edema because, again, it doesn't have, it has that lack of sodium loss that is needed to help with peripheral edema. So the most common and dangerous effect is this sudden drop in fluid levels. So you'll see that nausea, vomiting, hypotension, dizziness, vertigo, confusion, as we're not perfusing the brain appropriately, headaches, and then cardiac decompensation, and then hypovolemic shock. This is contraindicated for those with severe renal disease. Again, that this medication needs that increased blood flow and GFR to get the medication to where it works the best. It is also not used for folks with pulmonary edema. There are other medications that work much better and much faster, such as loop diuretics. Another place where we don't use it much is with active intracranial bleeding, because we don't necessarily want to decrease the pressure too rapidly, and you can correlate this to putting direct pressure onto a wound, where if you release that pressure, then it can actually increase the bleeding. Some other types of adverse effects that we see from this are convulsions, thrombophlebitis, pulmonary types of congestion. We already talked about headaches, chest pain, tachycardia, blurred vision, chills, and fever can also occur. So Mannitol specifically is only available in an intravenous infusion. There is problems with stabilization with this medication, and if it gets too cold, then it can crystallize. So it's usually kept in warmers or other warm places where there's temperature type controls, medication rooms where there's temperature type controls. The crystallization is also more likely to happen if it's in a higher concentration. So use of a filter is always required when administering this medication, just in case something happens where the temperature cools off during the administration and it starts to crystallize. So just a couple of other really quick ones. Of course, I don't see, or as mentioned, I haven't seen the use of these medications ever in my career, but osmoglin is oral form used for glaucoma, and then Urafil is another medication that's an osmotic diuretic that is also in IV form. So the next drugs we're going to talk about are potassium-sparing diuretics, Mirador, aldactone, and triametrine. Quite frequently see spironolactone or aldactone. This is the most commonly used medication, but triametrine is pretty frequently used as well. They are also known as aldosterone inhibiting diuretics, and that's because they block the aldosterone receptors. So they work in the collecting ducts at the distal convoluted tubules, and they interfere with the sodium-potassium exchange, which blocks the reabsorption of sodium and water that is induced by aldosterone secretion. So they competitively bind to those aldosterone receptors, and that's how these work. So how they're potassium sparing is they prevent the potassium from being pumped into the tubule, thus preventing it from being secreted so it stays within the system. They do competitively block the aldosterone receptors and inhibit its action. And then, like we said, like I said before, the excretion of sodium and water is then promoted. But these are relatively weak types of compounds when you're looking at them compared to thiazide or loop types of diuretics. So these drugs are used for different types of reasons, commonly seen for hyperaldosteronism, hypertension, also reversing potassium loss when we're using potassium-losing types of drugs and certain types of heart failure. One of the common features with heart failure is a hyperactivity of the renin-angiotensin-aldosterone system. So what happens is that the aldosterone inhibiting, they help because of the aldosterone inhibiting activity. And what has been found is that hyperactivity of that renin-angiotensin-aldosterone system after a myocardial infarction or heart attack causes a permanent type of damage to happen to ventricular wall called remodeling. And these types of medications have been found to prevent that remodeling from happening. So really helpful for folks that have heart failure following myocardial infarction. So again, we can just go through the systems of what we see as far as adverse effects through each one of the systems. Through the central nervous system, if there's adverse effects, you're going to see dizziness, headache, GI, so cramps, nausea, vomiting. I think we see nausea, vomiting, diarrhea with almost every medication as a adverse effect. So just plan on hearing that throughout the lecture whenever we talk about these. So other makes sense that there's urinary frequency, although weakness is another one of those things. Because they are potassium sparing, certainly hyperkalemia is a concern, so potassium levels will need to be monitored fairly regularly. So some of the things that spironolactone, some of the adverse effects specific to this medication that have been seen are gynecomastia, which is a growth of the breast tissue or tenderness and growth of the breast tissues, amenorrhea, irregular menses, and postmenopausal types of bleeding. And the problem is that it acts by displacing the androgen from the androgen receptors and sexual hormone binding, causing a higher estradiol type of production, which would lead to all of these other types of things. So thiazide and thiazide-like diuretics are considered to work equivalently to each other. Like loop diuretics, they are also chemical derivatives of sulfonamide antibiotics. So again, we want to be a little bit careful about folks with sulfa allergies, although this is found to be very rare that they will have any type of reaction. We still want to be aware of that and watch folks closely if they do have a known sulfa allergy. The most common thiazide and thiazide-like diuretics out there that we see quite a bit of are hydrochlorothiazide, or also known as HCTZ. And this medication comes in numerous combinations or combination products with other antihypertensive drugs or combo drugs that you will see out there on the market, or they're a part of different types of drugs. So their action is primarily in the distal convoluted tubule, which inhibits reabsorption of sodium chloride and potassium ions, and results in water, sodium, and chloride being excreted. But as renal function diminishes, the efficacy of thiazides diminishes as well, because the delivery of the drug is actively impaired. These medications cause direct relaxation of the atrials, which reduces peripheral vascular resistance or afterload, and they also decrease filling pressure or preload. So they're very effective medications for the treatment of heart failure and hypertension. As mentioned, I think it's important to keep in mind that as renal function diminishes or is getting worse, then the efficacy of these types of drugs is also diminished. But with metalazone, these this type of thiazide diuretic can be effective even when renal function is not at the best. So indications for use of these types of medications. So hypertension, again, it's one of the most widely prescribed drugs in this group, and as I mentioned, hydrochlorothiazide or HCTZ is in many combination drugs to treat hypertension as well. It is also used for edema, diabetes insipidus, heart failure, and again, many other used as adjunct drugs in treatment of edema related to many different types of problems, from heart failure to hepatic cirrhosis, estrogen therapies, etc. Again, looking at the adverse effects of this medication on the different body systems. For the central nervous system, dizziness, headache, blurred vision, paresthesias, decreased libido. GI, here we go, nausea, vomiting, diarrhea, lack of appetite. And electrolyte imbalances throughout the systems you're going to see resulting from that hypokalemia. So GU, as we talked about, decreased libido. There's also problems that could happen with impotence, with the skin or integumentary, urticaria, photosensitivities, metabolic, which we talked about electrolyte imbalances just a second ago, but hypokalemia, glycosuria, and hypoglycemia, those kind of things can also happen. So talking about all of the nursing implications or things that we need to do when we're taking care of patients that are on any types of diuretic type of therapy, and we always need to perform a thorough head-to-toe examination, but we want to get a really good patient history, including a really good medication history, because a lot of these medications will have issues with other medications. So we want to make sure that we get a complete history. We also want to assess baseline fluid status, daily weights, electrolyte balances, also looking at potassium levels, and we want to get vital signs, and then we want to get also some blood pressures. So we want to know how are they, and postural, so how are they sitting versus standing. So we want to instruct the patient that they should take these medications in the morning as much as possible to avoid interference with their sleep patterns, because these medications are going to cause them to be urinating a lot. And then when we think about the elderly population who are taking these medications, we also want to help them to prevent falls when they're getting up and down multiple times when they're still pretty tired and getting up to go to the bathroom. We also are going to monitor serum potassium levels for many of these medications. And then some folks will be getting some potassium supplements, but they're usually not recommended when the potassium level is 3 or better. We want to teach the patient to maintain proper nutritional and fluid volume statuses, so we need to teach them about potassium-rich types of foods when they're taking medications that are potassium wasting. We want to also talk to them about, if they're having potassium-sparing drugs, that they need to watch what the potassium-rich foods are, because we don't want their potassium to get too high. So some of those foods that we want to talk to them about are bananas and oranges, dates, raisins, plums, fresh vegetables, potatoes, meat, fish, apricots, whole grain cereals, and legumes. So for our folks that are also taking diuretics along with digitalis, we need to talk to them about digitoxicity. Although they've probably had information given to them on digitoxicity, they need to know that when taking diuretics, or many of these diuretics, it can increase their risk for toxicity. So talking to them again about confusion, palpitations, irregular pulse, visual types of changes, or seeing spots or blurred vision, those kind of things. And then folks that are diabetic who are taking thiazide or loop types of diuretics should also be told, if they're not already monitoring their blood glucose levels very frequently, that they need to be monitoring them frequently and watching for elevated levels. So lots of things need to be monitored here. So we need to encourage them to return for follow-up visits and lab work as they are going through this type of medication, whether they're starting on it or being changed or those kind of things. We want to teach them to change positions slowly because we are increasing the amount of fluid that is going out of their system through urination. They could have problems with orthostatic hypotension. So we don't want them just jumping up out of bed. We want them to sit up and take a couple of minutes to get themselves together, make sure that they're not feeling dizzy. And we want them to stand where they could sit safely if they start to become dizzy when they stand. So this is of great importance because we don't want them to fall. And then we want to encourage them to keep a log of their daily weights, so that way when they go to their doctor visits, they can talk to their doctor about it, and then they know when to respond or go to the doctor or call the doctor for further help if they're gaining weight too rapidly. We need to let them know that if they are sick and they've had nausea, vomiting, or diarrhea, they should let their doctor know immediately, because they already are, if they're taking these medications, they're already losing fluids pretty rapidly, or more rapidly than usual or normal folks. But then if they're sick and they have this increased fluid loss, they can get into trouble very quickly. We also want to talk to them about signs and symptoms of hypokalemia, so muscle weakness, constipation, irregular pulse rates, just that overall feeling of lethargy or weakness. We want to instruct them to notify their physician immediately if they start having rapid heart rate, if they have problems with syncope, or they're passing out, which could reflect that they're having hypotension or orthostatic hypotension or too much of a fluid loss. We also want them to let their doctor know if they're having weight gain. So if they're gaining more than 2 pounds a day or more than 5 pounds in a week, they should call their doctor and report this immediately. So just as an interesting side note, excessive consumption of licorice, not artificial licorice, but like natural occurring licorice, can cause or lead to an additive hypokalemia in patients that are taking thiazide, and that's because licorice contains an enzyme that stimulates sodium retention and potassium wasting. So there you have it, just a quick little fun fact about licorice and thiazides. So we also want to monitor them for other adverse effects like metabolic alkalosis, drowsiness, lethargy, again, hyperkalemia, both of those things. And just make sure that we are telling them the signs and symptoms of both of those. And then we want to monitor for therapeutic effect. Is this actually working? Are they breathing better? Do they have a reduction in edema? Is their blood pressure better? Do they have normal intraocular pressures? Is it working for them? So that is the end of this lecture. Sorry, guys. What I would like for you to do is I have created a discussion forum on my CR. It will open on the 20th, so tomorrow.